What is going on, everybody? It is Mark Cargila, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. At another episode of the Modern Pain Podcast this morning with my partner, Jared Hall. And this morning, we're going to be talking about a clinical process because we posted on social media. You need a clinical process. You need to have something that guides what you're doing day to day. Don't just fill up toolboxes. Get a process to know what it's all about, to know what tool with what patient at what time, the more specifics and the more nuance of it. And maybe avoid some of the things that Jared and I have, maybe paths we've taken in our career that looking back, we're probably could have did some more efficient ways of becoming effective and efficient in a clinic. But before we dive into our experiences in the clinic, let's welcome in our co-host. How are you doing, Jared Hall?
Man, I'm doing well. As you can see by my shirt, if you guys are watching, I am keeping it funky, right? Little hat tip to Fort Worth or Funky Town that I live in. No, I'm excited to talk about a clinical process because it's something that I didn't have. Like I didn't have for probably several months or maybe even years after I graduated.
Yeah. And I share this with our students in our programs too. Just like, my clinical process was, okay, I got a lot of stuff I've learned, and there's a patient in front of me. They got pain, and I'm just going to just chuck the kitchen sink at this patient because, by golly, something's got to help. And so a lot of times, thankfully, it did. We've had a decent average in the clinic. Provided maybe you're working in more complex scenarios where it's not as much of that natural history doing its thing. But I remember at the end of those things, I had zero idea of that kitchen sink of things I've thrown at a patient. Which one of those things really made the difference? And so I never could set up a clinical process where I was really learning in the clinic, because what we talk about with a clinical process is it gives you that n equals one kind of experiment that you can kind of learn, test, treat, retest, set up, where we're individualizing our interventions, and you're testing to see, is it making an impact on the patient in front of me, versus just, the cross your fingers and, man, I hope after that, barrage of things I've thrown at the patient that they're going to feel better. And it to me, it's that's where like experts gather and get to where these clinical patterns form much more quickly. Because the thought I've had with students is, okay, you chuck that kitchen sink at that patient, they get better. The next time a patient very similarly comes through, you're gonna have to chuck the kitchen sink at them again. What happens if we step back and you just really dissect that a little bit? You take each intervention, you kind of step back, you have a conversation with the patient, see where they're at, where it fits from a patient-centered perspective, and then you have some test, treat, retest measures to see within each intervention which one seemed to make the impact or change their what we call asterisk signs, and we can get into more of these things maybe later in the podcast. But which ones changed the things that the patient's looking for you to come in and change? And then you, next time, maybe it took you 4 treatments to get to the 4th one that eventually really made a difference and impact in there. So next time that patient comes in, because you validated that the first 3 weren't really doing much, you don't need to go through the first 3. You get to that 4th one right out of the gate, and you get to be much more effective. Now, of course, individualized treatments, there may be people that don't perfectly respond that way, but you'll often see clinical patterns. That's what we call clinical pattern recognition. And you'll see certain conditions that kind of present similarly in the clinic that often can respond to similar things, especially things that you find you work well in your practice. So why not get your practice efficient, especially when, man, you're getting a lot of patients in the door for some clinics, 4, 5 an hour, your efficiency is hugely important. I mean, it's important in any scenario, but man, if you got a pretty high productivity standard, that can be the difference between you burning out and you thriving in that standard. And so what's been your development, kind of that clinical process in your journey there, Jared?
Man, when I came out of school, like I said, I didn't have a process at all. It was kind of just like a bunch of knowledge with no real framework on how to apply it very well. And it was ask as many questions as I possibly could, try to get all sorts of information. And while the patient was answering one question, I was already thinking about what's the next question. While they were answering that question, I was already thinking about what's the next 2 questions I was going to ask them. And I wasn't actually really listening well to what they were saying, for one. And for me, if you're going to have any sort of solid framework or process, the foundational principle is actually really listening well to what that person is telling you asking good open-ended questions that maybe are going to help guide your evaluative process or give you more insight into where they sit. And then when I got to treatment, I would do a little bit of everything, right? I let's do a little bit of endurance exercise. Let's do some motor control exercise. Let's do some strength exercise. Hey, let's do this manual therapy and that other type of manual therapy and that other type of manual therapy. And I'm gonna hit them with a little bit of everything. And that way I'll paint with broad brush strokes, right? And like you already mentioned, well, then you don't really have any good insight into what may have not been good, what may have been good, and you're not really honing in on developing what you mentioned, that clinical pattern recognition for certain patients. And while nobody is ever the same, there are groups of people that do present somewhat similarly with different conditions and with different histories and that sort of stuff. So I didn't have any of what you could call heuristics to anchor my thought process. And that's interesting because my background training was pretty heavily influenced by a Maitland thought process. And Maitland had a great clinical process. And that's actually the process that I most closely follow these days with the SINS model, really listening for how severe is this, really listening for how, and testing and examining how irritable is this. What's the nature? Is it achy? Is it sharp? Is it tingly? Is it numb? Is there motor weakness going along with it? What's going on? And what's the stage? Like, did this just start? Was there a very clear mechanism of injury? Is it nebulous? Has it been going on for a long period of time? And now that thought process really guides my thinking on where I want to take the next steps after I evaluate a patient and while I'm evaluating them, but also even more so in the exercise, manual therapy, the treatment prescription, I guess you could call it. I need that data to have any chance of really developing a good plan, and not just a single session plan, but a this week plan, a this month plan, and maybe a for the next couple of months plan. I think when I came out of school, my process was to take it one day at a time, maybe sometimes 1 minute at a time, right? I had no forethought on what is the next session going to look like? What is it going to look like next week? What is it going to look like next month? And a lot of that is because you don't necessarily have the experience under your belt of seeing how people evolve over time and being part of that process. Um, but part of it was just not having any sort of clinical framework or structured thought process going into what rehab should look like.
Yeah, I think one of the things you talked about is just, knowing what questions to ask too, especially when, the big push as we should be as far as more person-centered care and, talking about the biopsychosocial model, obviously our best model going right now. Um, definitely caught a school. It was, I, I'm gonna interrogate you based on what I know from these PowerPoint slides I remember from school. It's going to talk about your tissues and tissue behaviors and all that stuff, and that's the strength of the Maitland system. And the Maitland system is definitely more than just the tissues as well. They do a good job of trying to really conceptualize the patient who's in front of you, and not just from a tissue perspective, but from a person perspective. And that's one of those questions and one of those concepts around questions where you got to learn how to have a narrative based process within your questioning and your initial examination, your patient interview. You need to be able to be efficient in your clinical process. How do you gather the information that best understands where that human is that day at that moment in that time that might predispose them to being more not in line for a manual therapy treatment, or may have different things that are going on in their life that need to be talked about before you can start really moving forward, or some contributing factors that are going to be important discussion pieces. Maybe it's diet, sleep, stress, who knows what it is for that patient, but being able to question some of those things that I don't think we really get too much of a really good grounding in that. I'm sure it's improving, I'm sure, in DPT education, but not as much as probably we'd like to see. And but it's hard to cover the whole gamut of clinical expertise in PT school. Being in academia a little bit, I've recognized that we got to get safe clinicians who pass board exams and who can enter the profession and be safe and effective. But to be good, it's a different animal with a clinical process. That's where the clinic becomes your teacher. That's where the process too. I probably would say I don't want to say wasted, because it wasn't wasted, but I didn't have as much of an effective and efficient first probably 5 years of my career, because I had zero process. It was just getting habits of things I throw at people without any real ways to validate what I'm doing beyond just natural history rolling through the things, and I'm, entertaining it. But yeah, that clinical process can really help you zero in early in your career to start charting your course of what things are working with what patients, and those patterns start forming more quickly. And the more people you see, the more patterns you see of conditions, that this is how that condition presented last time. These are the things that worked last time. I'm going to go right to those things this time with this patient. And you start becoming a lot more effective, and you, again, hopefully stave off a little bit of the burnout that can be a big problem with it. One of the things we were talking, Jared, before we came on the podcast was this thought of like humans being dynamic systems, and where, there's multiple variables at play when you got patients in the room. And I think we tend to want to think that the patient is a very univariable type, entity with where we're just going to a kinesiopathological model of, let's just go after the tissues, pathologize, and get some names out there that I can pathologize and treat. But obviously, it's a little bit more detailed than that, a little bit more complex than that. What are your thoughts on students in early career professionals, maybe even existing professionals who've been out for a while, who maybe haven't zoomed out past that kinesiopathological model, and maybe what are some concepts they could kind of take into mind to better understand that stuff and help their patients, of course?
Yeah, that's a good question, because I think that for students in particular, um, on average, we're taught a very linear type approach, right? It's a very X versus Y. Like, if I do this, then I'll get that response, and if I do that, then I'll get that other response. And there's no variability in there. There's no room for unexpected feedback or unexpected answers. When in reality, I have a handful of foundational principles, or you could call them heuristics or whatever it is, that kind of guide my thought process. And one of those, like you mentioned, is that the human is a dynamic system, which means that if you put in X, that doesn't mean that you will automatically get Y to the system, right? You could get Y minus Y squared, you could get Y to the 15th power. Like, you don't know exactly, because when you add a stimulus, or you add something to the system, there's a lot of different feedback. There's a lot of different responses that you can get. And there's a lot of different variables from a bio perspective, but also from a psycho perspective, from a social perspective, from the way that these interact with each other, from history of different injuries in the past, and exercise experience, and thought processes, and expectations, and current emotional status, etc. Right? So you're not always going to get out Y when you put in X. So that's foundational as part of my clinical process. And then other things would be that the human being is adaptable. That is a foundational thought process that I have in my framework. That means, we can either have habituation, or we can have sensitizations. We can have adaptation and maladaptation for different levels, different tissues, different psychological resiliencies, all this sort of stuff, right? So I like to think about the human being as adaptable, rather than a finite resource where their knee only has, X amount of bends in their life, or their back only has X amount of box lifts, and then they're just done, or we have to have this perfect, mechanical approach. I tend to think that up to a certain point, every human's body has a capacity for adaptation. And I try to structure my thought process, and try to structure my exercise prescription under that umbrella, or through that lens, that we're trying to create adaptation, and we're trying to maybe create habituation rather than sensitization, and that sort of stuff. So the only way to really, I think, develop that is to be able to zoom out and realize that you're looking at somebody that isn't just a body. It's a body and a brain and a dynamic nervous system that exists within a really complex environment, which exists within a really complex culture. And there's arrows going up, like the lower levels affect the higher levels, and there's arrows going down, the higher levels affect the lower levels. And if you don't have that thought process yet, or you haven't conceptualized that, it's going to be really hard for you to develop a more, maybe nuanced or more comprehensive framework when you work with people.
Yeah, you mentioned a lot of heuristics a few times this podcast. So it's a mental shortcut that a lot of times you develop as you kind of see things, and you use these. If we go to Kahneman's type 1, where it's just fast, reactive, kind of drawn off a past experience type thing, versus type 2 thinking, be more cognitively heavy thinking, where you're really thinking and picking things apart and really having a lot of that cognitive process of picking through processes and different things to where eventually you can make these mental shortcuts. Some of them very good and helpful, and we all use them well clinically. Your brain's very seeking to be an efficient metabolic activity throughout the day, so instead of being very high metabolic load that the brain tends to be. So if we can have some shortcuts that help the brain work less hard, then your body tends to go that way. But you just got to be aware that sometimes they're good, sometimes they're bad. But being aware of them is the first key part, which Jared has done nicely. But I like the adaptability and habituation thought processes too. I think sometimes we want to pathologize, and that it's like you're pathologized or you're well. It's this continuum of eventually, yes, can we start introducing things into the system that person can habituate to, knowing a lot of the factors that you pointed to. There's a lot of things that are dynamically interacting and acting on that person at any moment in the clinic, and it can change session to session. If you've ever had patients who've come in with a poor night's sleep, or you've had patients who've had a hell of a, maybe they've had a fight with their spouse, or they've had different things that, traditionally we don't think, oh yeah, there's a file in the background, let's go do our PT now. Where, hey, that stuff definitively often can impact how they perform, how they're reacting to some of your treatment techniques that, man, they responded so much better last time. But, it's not always the case where those things impact, but I definitely have seen it more than once where you see these things that happen with patients. And then also, how many of you have seen patients where, man, life all of a sudden takes a turn for the good, man, something great happens and man, the body's feeling good. They're crushing it in PT. It's just like all of a sudden they're a different person. And again, we should not take credit for that. I mean, definitely we coach them, say, look at what your body's doing now that this problem's handled in your life or whatever it may be for that patient. But yeah, looking at the process more than from a tissue deep level and looking at the process from a human level. And that's a very complex level to look at. But some of these processes allow you to kind of unpack, what's the unique person's psychological status? What's that unique person's social status? What's the unique person's, biomechanical status too? Because that we don't definitely think that's not important. It's important stuff for the right patient at the right time. Because I don't want to get fielded with a bunch of comments here on the podcast that we're just completely jumping into the psychosocial realm and just forgetting that, sometimes those mechanical factors matter. But again, you need a process to determine if they matter, not just assume they matter for that patient in that treatment room that day. So yeah, that's the key with the process. And I would highly recommend you guys. I mean, the Maitland process probably foundational in our profession as far as, a good clinical process that really kind of encapsulates the whole person. There's other great processes with cognitive functional therapy. There's Matt Lowe does a lot of great stuff with his vector diagrams and looking at person-centered ways of looking at things. I mean, there's a lot of people kind of putting frameworks out there. The problem is there's a lot of stuff like, from traditional manual therapy frameworks to cognitive functional therapy. What do you recommend kind of in that realm, Jared, to kind of bring it all together? Because it's sometimes can be a sea of social media posts and infographics of how we should be doing it. But what do you think it would be a good strategy for folks to tackle some of that?
I mean, that's a really good question. As you were talking, I was thinking there are some good processes out there, right? There are some good frameworks. Matt Lowe does a great job with the dispositional model, and Peter O'Sullivan does a great job with cognitive functional therapy model. But the thing is that most people in clinic don't have somebody that they go to and they ask questions, and they don't have somebody that goes to them and asks questions about what their thought process is. Why did they choose that intervention? Why are they going down that pathway? Why are they thinking what they're thinking, right? So a lot of times we're left to our own devices to try to figure out these processes and figure out what we're doing in clinic by ourselves. And we don't have, we don't even know what we don't know, right? We don't know what our own biases are a lot of the time. So we're stuck in a little bit of a bubble, evaluating our process through our own biased lens, and we don't have a third party person that's asking us for feedback. And I don't want to do too much shameless self promotion, but this is our podcast, so hey, let's do it. I think that having somebody like in a coaching or mentorship role is one of the most pivotal things that you can do for your career, to have a third party that you trust and that you think is evidence-based, that you think is doing a good job. And, you and I like to think that we're at least trying our best to do that. to ask you questions and to guide you and to provide feedback and to kind of cut away some of the chaff, and really dive into what is your thought process? What is your clinical reasoning? Why did you choose that direction? Hey, have you ever thought about this? Have you ever looked at it that way? Why don't you go down this path? And the vast majority of us, we just graduate and we go into clinic and we're trying to figure it out ourselves. We don't have somebody set up in that formalized mentorship role, except for the very small amount of people that do a formal residency, which that's not necessarily a geographical or financially feasible approach for a lot of people.
Yeah, yeah. The residency approach and even the fellowship approach, it's not an option for some people. And a lot of clinicians too come out of school, they get thrown in a clinic by themselves. I remember having, classmates getting out and they're like, "Oh, I got this director position," like, and they're by themselves. And to me, that's you're going to create the most biased environment possible because you're going to only see the world through your eyes. You don't have any other eyes looking at your practice. You don't have anybody else to say, "Hey, is there other ways you could look at it and think about it?" I think getting mentorship regularly, and it's something I seek regularly, to just have people looking at my practice. So I don't just start zeroing in and missing big picture stuff because we're humans. We tend to kind of narrow things probably to a fault at times to where we think we're seeing it the right way. And it's just good to have other eyes, mentors, coaches, different things that can help you kind of zoom out of your practice, look at big picture, consider other things. The big thing with our coaching program that I've enjoyed is just seeing clinicians develop that process and have other clinicians kind of weighing in on what their decision making is. When we have these coaching calls, it's fun to watch clinicians trading thoughts back and forth and different things with, "Hey, here's what I did in my practice that with that kind of thing. Have you tried this?" And it's been interesting. I've learned. I think the selfishly, when I'm a different human than Jared is, than our coaching folks are, and they're going to see things differently than I see things because they've experienced a life and have a context they bring that's different than me to a treatment room. That I've had numerous times where I'm like, man, I didn't really think of it that way or approaching it that way. It's an interesting way to go about it, but yeah. If the coaching thing is something of interest to you and you're hearing Jared and I talk of it, of course, it is a program we run. There are great options out there. We've mentioned a few of them today. Our option is through our Complete Clinician Supercharge program, where we do exactly what Jared said. We get in your practice. We kind of talk you through what you're doing, why you're doing it, get you honed in on the clinical process so you can start being efficient. We've talked to a lot of clinicians about documentation and career directions and things more than just what we thought would be just strictly a clinical program. But if it's something you're interested in talking to us about, if it might be a good fit for you in your program or in your practice and where you're at and with some of the struggles you are having, then jump on modernpaincare.com/supercharged. You can book a call with Jared or I, and we'll sit down with you to talk and see if it's something that might be a good fit for you. If not, we'll definitely point you into some directions of some resources and folks. The nice thing, Jared and I've had kind of lucky to have a network of folks that we can often refer people to. I've had a few folks in the VA system who have some unique VA type questions, and thankfully we got Katie Schottmeyer and some other folks there at the VA that I say, "Hey, you need to talk to Katie because she knows 100% of what you're dealing with and can help you out with that." So, with that said, Jared, is there anything else you want to leave folks with before we end up for today?
Uh, no, just like if you feel like you don't have a process right now, and don't get upset with yourself, don't get frustrated. I know that I felt really frustrated, especially early on in my career as a new grad. Some of that comes with time, and you can speed that up if you seek out strategic mentorship, and that's just what we're all trying to do. We're all trying to get better. We're trying to serve our patients better. You can't kick yourself when you go home at night just because you haven't developed into a master clinician in a couple of months out of school or even a couple of years out of school. And I know that that's something that a lot of people consistently struggle with, and it's something that I struggled with a lot.
Yeah, yeah. That journey of expertise is one that never stops. There's no destination there. It's a day in and day out one that you just need to get a process to where you're getting better every day. And I think Jared and I both still look at each day in the clinic as a day to get better, a day to learn, and a day to get humbled from time to time. Definitely still happens regularly. But being open to it and having a process to grow and learn from every opportunity in the clinic, man, it's what separates to what we think is true clinical expertise is really getting a process as early in your practice as you can to where that clinic has you grown and instead of burning out and wanting to quit and doing the things that I did earlier in my career. So don't get to that point. Seek out some coaching and mentorship. and get your process honed in so you can start being effective and efficient in the clinic immediately. So anyway, with that said, if you have any other questions or comments or things you want to hear us talk about in the podcast, definitely reach out to Jared or I via social media. You know where to find us on Instagram or Facebook. You can email me at mark@modernpaincare.com or jared@modernpaincare.com, and we'll happily answer any questions through that medium as well. But that's all we have for this week. Hope you guys enjoyed the episode, and we'll see you next time.